Hi, this is Caitlin Carter. This is for Clinic 3050. This is my required skill module on the 6-week postpartum visit. So, I would start this visit by, having the client come in, or if it's in the home, just kind of a general, how are you doing? I like to start off appointments by asking them if they have any questions as they come into the appointment, because I think it's easy to kind of get lost in conversation, and I wouldn't want to miss something that they specifically wanted to chat about. Normal oohs and ahs over the baby, all of that sort of good stuff. And so as I'm doing this, there's just a whole lot of kind of general assessment that's happening right now. I'm watching for things like really, how does she look? Does she look completely exhausted and frazzled? Is she kind of looking normal? I mean, as normal as a new parent is with a tiny new baby. I'm also watching for things like bonding. Is she connected with this baby? Does this baby look well cared for? Just those sort of, just to get a general feel on the situation. So I would go through any questions that they have, and oftentimes a lot of questions will come up. I find this to be kind of a longer visit. First of all, because we have a lot of things to talk about, and second of all, because it's their last visit with their midwife and they don't want to say goodbye, which is wonderful. And anyway, so of course we're going to be doing vitals, blood pressure, pulse. Some people do temperature and respiration. We don't with my preceptor, but that's on the list of things. I would be reviewing kind of the list of herb supplements, any medications that they're taking, and making more suggestions as they go along. If there's things in there that need, if they're anemic, we're going to talk about blood building supplements, that type of thing. Depending on how their birth went and how bleeding is and things like that, it may be appropriate to do a blood draw, pull a CBC, just to check out the hematocrit and hemoglobin levels. Also, we would be obviously knowing our clients are just as individuals. We have a client coming in for a postpartum visit on Wednesday that had a fetal maternal hemorrhage. And of course she was GBS negative, or not GBS, RH negative, and our baby was RH positive, and she did have a positive Kleihauer-Betke test. So we will be reevaluating that at the 6-week postpartum visit, just making sure that, that there's no surprises in future pregnancies, things like that. We're going to be discussing, perineum. How's your bottom feeling? How's, if they had sutures, do we feel like that's all healed up? Typically wrapped up in that conversation is, sexuality type stuff. Have you had intercourse? How'd it go? Was that painful? Was there problems? Usually we have kind of a sexuality chat at the 2-week postpartum visit, because we were finding that when clients came in for their 6-week, that they were kind of nervous to tell us they had intercourse because they felt like that was breaking a rule or something. And so we started having that conversation a little bit earlier. Most people at 2 weeks postpartum are not interested in sex, but by the time week 3, 4, 5, 6 rolls around, for some people that's not sounding like such a bad idea. So we will hopefully have already had that conversation, but at this visit particularly, we want to know, are things functioning, are they not, and how they're feeling. Obviously, it's really easy for emotions to become involved here as well, and I really encourage people to, just communicate with their partner, mention things like, postpartum hormones, breastfeeding can cause vaginal dryness, and that lubrication and communication, I like to talk about those two things. Also, if people have a history in the past of not having intercourse for 6 months or a year or something, no research to back it up, but I feel like 4 months is a, if you feel like there's no reason to have not had intercourse by 4 months postpartum, or if it's still painful, if there's still problems, give me a call. We will get you hooked up with somebody that can help, whether that's like pelvic floor therapist or sex therapist or any of those type of things. I feel like this is one of the conversations that gets neglected a lot, and is really important. I mean, we want our clients to have good sex lives after they've had babies, if they want that. So that's a conversation that comes up. We'll be reviewing the client's chart to see if they are due for a PAP and if they would like a PAP. We find that a lot of people want us to do a PAP instead of going someplace else. However, we will also be reviewing family planning and what their plans are for future kiddos, and if they're wanting something that we can't help them with, such as a prescription for birth control, or most importantly an IUD. We will not do a PAP at our visit if they have an appointment next week to go get an IUD. I don't feel like there's any reason for to put the client through 2 vaginal exams in a week's period of time, just so that I can do a PAP. Somebody else is already going to be in there. If they're inserting an IUD, they can do a quick swab for PAP. We'll also be reviewing, how old they are and the guidelines. If they're under 30, they should have a PAP every 3 years. If they're over 30 and are willing to do a PAP and an HPV screen at the same time, then that guideline is 5 years. So I like to tell them that just so they know that. Most people, I feel like, don't know that. Myself included. That's no judgment. We just talk about those things. If they are wanting a PAP, we would go ahead and do that. And with the vaginal exam, I'm checking several other things, just that I'm making mental notes or that I'm, talking about. Perhaps the client said that they were having pain with intercourse and it was in one particular spot. I can check that spot, see if there's any signs of infection, unhealed laceration, sutures remaining, or if there's just a lot of tension. Maybe they were in kind of a weird position as they were pushing. Any reason to help them, if they need, like I said, pelvic floor therapy or something like that. I'm visually assessing external genitalia, particularly if there were sutures, things like that. If I'm already, if I'm having a reason to be internal, I am definitely doing bimanual, 2 fingers in with the dominant hand, hopefully 2 fingers, and I'm assessing cervix, how that feels, and bimanually assessing palpating uterus, which really shouldn't be palpable at all at 6 weeks, and I'm assessing either side. I'm not showing you very well. Either side for any issues with the ovaries. And I did have, it's been like a year and a half ago or now something, I was like, I feel like when I'm doing that, I'm like, yep, nothing there, nothing there, nothing there. Okay, great. That seems normal. I did have a client that was, that kind of had definitely more of a mass on one side, and she had an ovarian cyst. She got back to me later and reported that she'd gone to an OB and had an ovarian cyst on that side. So no news is good news. I think that's all of the internal things that I'm doing. Oh, I'm also assessing for, I will ask him to do a Kegel, and I typically have my fingers this way, so I'm assessing the vaginal walls, and then I will turn my fingers this way and have them do a Kegel there as well. So I'm assessing the anterior, posterior components, so I feel like that's all with that exam. I will also want to do an abdominal assessment. I assess for diastasis recti at that point in time. and make appropriate recommendations based on that. I feel like I'm rambling. I don't know how much detail to go into here. I'm having them lay out flat to assess for the diastasis. I'm starting at just below the rib cage, just below the xiphoid process, and having them tuck their chin and lift their head up to kind of do a mini crunch right there. And I'm assessing, pressing downward and seeing how far the separation is. And I typically go, I don't know, maybe 5 different times between there and the top of the pubic symphysis, just to assess what's going on. And I make recommendations on exercises or what exercises not to do at that point in time. One of the programs that I really like, both for pelvic floor support and diastasis healing, is the MooTube program. We talk about that a lot, especially if, I think it's fabulous anyway. If there's, if this is a client that's not going to go to pelvic floor therapy regularly, things like that, I feel like the MooTube program is just a really good, all-inclusive plan for clients that they can do at their own pace. So we typically talk about that, but I'm happy to make PT referrals as necessary, if that's what they want, if that's indicated. Also, as we're talking about, any type of pelvic floor type stuff, I'm asking questions about urinary incontinence. Are you peeing only when you intend to? Do you ever pee when you don't intend to? Such as sneezing, laughing, with exertion, things like that. And I always say something about, while this is really common, and a lot of women experience this postpartum, that doesn't mean it's necessary, and nobody should be wetting their pants. There's definitely ways that we can fix that. So I have a conversation about that as well. And voiding as well. Bowel movements, like cystocele, rectocele type stuff. Basically, just internally, is everything where it's supposed to be? Are they being able to eliminate effectively and completely? We would have talked about bleeding as well, postpartum bleeding. They should not have any leukemia at this point in time. Sometimes women will have experienced recently, just like a 1-day bleed. They're like, oh, maybe my period's starting. And we kind of talk about that. That can be a hormone shift right there, that it can just be, a spot for a day or two. But that doesn't necessarily mean that they have started their period again. Which would lead us to the conversation of asking them, if they've had multiple babies, like when did they get their period back after their last pregnancy, that they can typically expect to have the same. If they've got their period back at 8 weeks, that can typically be the same, but that it can also not be the case, that they could easily get their period back before that. And we have a conversation about how the body ovulates before menstruation occurs. So there's the possibility of getting pregnant before even having a period, just so that they're really aware of that. I have a personal example to share about that. I feel like it's really important that people know babies really can happen before you have a period. And if they're, again, so we're talking about birth control, if that's something that they want. If they are not wanting birth control, we talk about how long may be appropriate, spacing between children, especially, if there were complications or, just physical depletions, things like that. Nursing a baby, is their baby up every 2 hours? Is their baby sleeping 6 hours straight? And that will also play into the conversation as far as when they may get their period back. Maybe they didn't get their period back for 2 years with their first baby, but their baby was a horrible sleeper and was up all night every night, and their second baby is sleeping through the night at 6 weeks. They're likely gonna start a regular menstrual cycle sooner. God, I feel like I'm rambling. So much of this is individualized. I feel like, the conversations can branch out easily, however that goes. let's see, throughout all of this, I'm assessing their emotional well-being as well. I'm kind of asking, do they have questions about their birth? Do they have anything that they wanted to talk about there? How's the partner dynamic? How's big sister like the new baby? Just all of those family dynamic things. Is this mom well supported? Do they have help? Are they are they being able to function normally? And checking for signs of IPV. Is this person safe? How's things with their partner, their living environment? And I really like the Edinburgh Postpartum Depression Scale. I think it's super easy. I know not all midwives use that, but I think it's very, very important to have just a conversation about, like, how are you doing? How do you feel like you're doing? What would your partner say about how you're doing? And just say there's lots of extra community resources available. Therapists, if, again, such an individualized conversation. Definitely screening for PMADs though. And that conversation kind of leads into the social support type conversations. Again, with the family dynamic and parenting. We have some really great support groups in our area. I may recommend, there's like MOPS type stuff. We have a Hope Circle group in our area that's specifically for postpartum moms. During this COVID time right now, they're only meeting online. And that's just a safe space, a safe, non-judgmental space to just talk about the realities of being a new parent. Yes, we love our babies, and yes, they're adorable, and it's wonderful, but it's not all wonderful. There's, sleepless nights and endless laundry and toddlers that always want fed, and it can just be exhausting. And so there's a really great support group for that. I have a handout just with local parenting resources that's good, if people are wanting that more communal support. We're also talking about, as we're talking about support, if they work out of the home, when will they be returning to work? All of those conversations as well. I think that's about it. In the state of Washington, we are no longer babies' care providers at 6 weeks. That only goes until 2 weeks. But I still always, listen to heart rate and respirations, just kind of do a little quick once over. We'll get a weight on the baby. I don't take baby's clothes off and things like that. Just, kind of toss them on the scale and see how they're doing. Most of our parents will have seen a pediatrician. I don't know about most. Anyway, just to make sure they have, a relatively accurate weight on baby, so they know kind of how things are going. If they have any concerns with baby, sleeping, crying, alertness, that type of stuff, hopefully that would have come up way before. But do make sure that they have a primary care physician, whether it's a pediatrician or a general family practitioner, nurse practitioner, so they know that if there's a problem, that they know who that they would go to for that. And I think that's it. We end the appointment by, of course, talking about if they need anything, that we are, I say clearly, even though we are no longer your care provider as of today, we're always available for referrals. If something's going on, if you need something, call me, shoot me a text. I can connect you to the right person. Because I feel like so many, women typically, clients are leaving our care and really they're not going to see somebody else unless they're needing birth control or something like that we can't provide. But so many people are not going to go back to the care of somebody else. I feel like it's important that they know that if there's a problem, there's somebody that they can reach out to for that. So I think that's it. I will stop rambling. And yeah, thank you.